Hello, everyone. Welcome to the webinar on exposure units and estimating exposure point concentrations. This webinar is part of the Public Health Assessment, or PHA, webinars training series. Here, we will introduce you to the initial steps in the health effects evaluation process, which is how to define exposure units and how to estimate exposure point concentrations, also known as EPCs. This webinar is sponsored by the Agency for Toxic Substances and Disease Registry, or ATSDR. For reference, you can find the presentation slides I'll be using and the recording of this webinar on ATSDR's website. The files are available in accessible format for people with disabilities. I'm David Millard, a toxicologist with ATSDR. Today, I am joined by James Durant from ATSDR and Rebecca DeVries from Eastern Research Group. I'm the Associate Director of Science in the ADS office within the Office of Capacity Development and Applied Prevention Science, and I've been with ATSDR for over 35 years, doing PHAs and developing guidance documents. James, would you like to introduce yourself?
Yes, thank you, David. As mentioned, my name is James Durant, and I'm a certified industrial hygienist. I've been with ATSDR since 2002, and I've been a health assessor and worked in exposure investigations, emergency response, and data analysis. Now I'm with the exposure investigations section in the Office of Community Health Hazard Assessment. Rebecca, would you like to introduce yourself?
Yes, my name is Rebecca DeVries, and I'm an environmental health scientist with ERG. I have a background in environmental epidemiology and risk assessment. I have worked closely with James and David over the years on several guidance documents that focus on different parts of the public health assessment process, including identifying exposure units and calculating exposure point concentrations, or EPCs, which we're talking about today.
This webinar is based on the online Public Health Assessment Training Module 7, called the Health Effects Evaluation, which teaches the various steps in conducting a health effects evaluation. Let's go over the objectives for the webinar. I will first provide you an overview of how ATSDR evaluates the potential for health effects in exposed populations. Then I will briefly introduce how to summarize the findings. We'll also present some limitations and uncertainties to consider when evaluating exposure units and EPCs. We will discuss how to incorporate health outcome data, also called HOD, into the public health assessment process by using ATSDR's HOD decision criteria. We will provide you some take-home messages to consider before you conduct an HOD evaluation. Then we will identify how to define exposure units and how they fit into the PHA process, and how to compile data for each exposure unit. Finally, James will identify how estimating EPCs fits into the PHA process and how to estimate EPCs for either discrete sampling data or non-discrete sampling data. In the screening analysis webinar to come, you will learn how to identify potential contaminants of concern, often called potential COCs, by determining which contaminants have a maximum concentration that met or exceeded media-specific screening values for soil, water, air, and vapor intrusion. These include ATSDR-derived comparison values, also called CVs, or non-ATSDR screening levels developed by other agencies. You also identified potential COCs when there were site or contaminant-specific factors that warranted further evaluation, such as community concerns about a contaminant. In this webinar, you will learn all about the initial steps in the health effects evaluation process. The health effects evaluation is ATSDR's process to closely examine potential COCs for completed and potential exposure pathways and durations of interest. It involves using site-specific factors to determine whether exposures may potentially cause health problems and whether health effects action is needed. It's also important to note that certain contaminants will need special consideration during the health effects evaluation process. Examples include asbestos and radionuclides. If you have contaminants such as these, consult with a subject matter expert, also called an SME, on the best approach for evaluating them. Also, you may find that a non-cancer health guideline or a cancer risk toxicity value is not available. If this occurs, you should select the contaminant and evaluate it as part of the health effects evaluation. Okay, let's begin with a question about what is covered in the health effects evaluation. I'll read the question and want you to think about how you would answer it. Question 1, select the incorrect answer to the following statement. Remember, the incorrect answer. ATSDR conducts a health effects evaluation to select contaminants of concern for each exposure pathway, calculate hazard quotients and cancer risk, determine EPCs for each contaminant of concern and duration of interest, or conduct an in-depth toxicological evaluation. Those who selected A had the correct answer. That is not part of the health effects evaluation process. The other 3 steps are, as you remember, selecting contaminants of concern for each exposure pathway is done earlier in the health assessment process. And the 3 areas I just mentioned are the ones that are part of the health effects evaluation process at ATSDR. As shown in this flowchart, the public health evaluation process has many steps. Typically, the primary technical components involve evaluating exposure pathways, screening analysis, shown here as identifying potential contaminants of concern, EPCs, and exposure calculations, and finally, an in-depth toxicological evaluation to determine possible health effects. The sequence of steps may differ slightly depending on site-specific factors. For instance, health assessors may define an exposure unit before or after the screening analysis. With large data sets, health assessors may decide to complete the media-specific screening on the entire data set to identify potential COCs at the site, and then define the appropriate exposure units for further analysis. For smaller or more defined data sets, the health assessor may decide to define the exposure units before the screening analysis, which is shown in the figure here. Health assessors will use professional judgment to decide when to define exposure units. However, they must define them before determining the EPCs. For these reasons, we present concepts around exposure units and EPCs together. Once you have determined or calculated your EPCs, health assessors will then take those values and put them in the ATSDR's Public Health Assessment Site tool, also called FAST, to calculate doses, adjusted EPCs in air, hazard quotients, and cancer risk. And those that are above an HQ of 1 or a cancer risk of 1 × 10⁻⁶ will then be brought into the in-depth toxicological evaluation section. The topics in this diagram that we will cover in this webinar are indicated by the 3 red arrows on this diagram. They include defining exposure units, estimating EPCs, and summarizing health effects findings. I also want to give you some information on HOD, which has evaluated some, but not all, sites. Before we get into conducting the major steps of the PHA process, It's important to think about the limitations that could come into play with each step in the PHA process. Thus, I will discuss a little bit about summarizing your health findings and discussing uncertainty before going into the steps for defining exposure units and estimating EPCs. Before we dive in, it's important to discuss some terms that are key to understanding the health effects evaluation process. We will focus on two primary terms for today's webinar, which are exposure unit and exposure point concentration. The other terms on this slide include exposure dose, exposure parameter, exposure factor, adjusted air concentration, health guideline, cancer risk toxicity value, hazard quotient, and cancer risk. These terms will be discussed throughout the PHA process and during other webinars. The PHA Training Module 7 covers concepts related to EPCs and exposure units in two primers embedded in Module 7. Many guidance documents and tools are located on the resource pages of the Public Health Assessment Guidance Manual, or FAGM, and the Public Health Assessment Site Tool, or FAST. Health assessors should also review the EPC and exposure unit guidance documents on the FAGM resource page. In addition, ATSDR has two webinars detailing the EPC guidance for discrete sampling and for the toxic equivalent, or TEQ, guidance for dioxin and dioxin-like compounds. Also, the guidance for identifying exposure units for the PHA process that we're covering today is available on the FAGM resource page. ATSDR also has guidance available on the FAGM resource page for evaluating how to determine an EPC if you're presented with sampling data developed from a non-discrete sampling approach. You may remember that as composite or incremental sampling approaches. In addition, ATSDR has guidance on how to calculate an EPC if your site has a mixture of polycyclic aromatic hydrocarbons, or PAHs. Also, ATSDR also developed an EPC tool that calculates EPCs to be used in FAST. Both the dioxin guidance and PHA guidance were used to develop the EPC tool, which should now be used to calculate EPCs for both these chemical classes, as well as all other chemicals at your site. More information about how to do this is in the dioxin and PHA training videos available from the FAST resource page. ATSDR health assessors and partners, and those involved in the PHA process, can gain access to guidance and tools in FAST by sending an email to phast@cdc.gov. Numerous guidance documents on these topics are available as well on the FAGM resource page. You can also find various ATSDR webinars on CDC's YouTube channel. I know finding all these training and guidance materials could be confusing. My suggestion is that you go to the FAGM and FAST resource pages and search the page using the term webinar or guidance. This will highlight all our training and guidance materials, making it easier for you to find the training and guidance you're looking for. Okay, now let's talk about summarizing findings and considering uncertainties. As we go through the steps of the health effects evaluation process, you should think about the way you will focus on the main points of how site-specific exposure estimates compare with health guidelines and cancer risk values, whether possible health effects might be expected, and any uncertainty with these findings. In your documents, you will need to clearly explain what is known and where and why there are uncertainties. Also, You will need to state how you accounted for uncertainties in your conclusions. Whenever possible, ATSDR typically accounts for uncertainties by using reasonable maximum exposure estimates as the basis for determining whether adverse health effects are possible. However, even with health protective approach, there are inherent limitations and uncertainties in the PHA process that must be considered. We will discuss some of those next. This table has different types of potential sources of uncertainties to look for, and examples of each type related to material covered so far in the PHA process. Rebecca will point out other uncertainties and limitations related to defining exposure units. One example of uncertainty includes limited number of environmental samples. If you do not have enough samples to characterize an exposure unit, then the concentrations in your data set may greatly overestimate or underestimate the true EPC. This is particularly true when you have to use the maximum concentration because of limited sampling data. When you are required to use maximum concentrations in your document, be sure to describe the uncertainty this adds to your evaluation of possible health effects. Another example of uncertainty relates to exposure units and fate and transport. As you recall from the webinar on sampling data, for the groundwater pathway at the Gala Lumber Company, or GLC site, we do not have a full understanding of the fate and transport of groundwater contaminants off-site to other private wells, besides the 4 wells where we have data. Let's talk about other potential sources of uncertainty. Another example of uncertainty is when there are a large number of non-detect observations. You will learn later in this webinar that if you do not have a minimum number of detected values, then you will not be able to calculate a 95 upper confidence limit of the mean. This term is often called the 95th UCL of the mean, or the 95th UCL for short. If you don't have enough samples or enough detected values, you may be forced to use the maximum concentration as your EPC, which can introduce more uncertainty into your evaluation and conclusions. More on this later. Finally, for sources of uncertainty about populations near the site, you should try to find out as much as you can about the characteristics and activities of the population surrounding a site. These include what time frame were residents exposed, past, present, or future? Are sensitive or susceptible groups present? If fish is the pathway, are subsistence or recreational fishers present? Is information about gardening available? This knowledge may help to reduce uncertainty and make your evaluation more site-specific. However, some of these uncertainties can be overcome, as I mentioned, by health protective assumptions you make during your health effects evaluation. Now I will switch gears and turn to evaluating HOD. As many of you know, HOD are reportable statistics or information on births, death, and diseases that characterize a population's health status and are occasionally evaluated in our documents. This slide shows some of the types of HOD that ATSDR might review in our work. ATSDR obtains and reviews HOD for various reasons, and I will mention some of them. One is to respond to community health concerns. Another is to provide information on the health status of a community, to examine whether people are experiencing health effects at the same, lower, or higher rate than expected. Also, a reason might be to determine if any higher than expected rates are increasing over time. One last example is that evaluating HOD may generate hypotheses to be tested in a more rigorous epidemiological evaluation. Thus, HOD are used as a stepping stone to identify the need for potential follow-up health actions, such as an exposure investigation involving biomonitoring, more rigorous analysis, or health surveillance. There are various types of HOD that ATSDR might review. Some include morbidity data such as cancer incidence or birth defects from state or county registries, mortality data such as death certificates, and health statistics from community health studies. ATSDR is required by the Comprehensive Environmental Response, Compensation, and Liability Act, or CERCLA, commonly known as Superfund, to consider the evaluation of HOD during our PHA process. The law indicates that ATSDR should include HOD analysis where exposure to site contaminants could have resulted in the development or worsening of health effects. At the onset of the PHA process, the health assessment team should plan community engagement activities to learn about community concerns and to provide information on ATSDR's products and services, including the usefulness of evaluating HOD. Specifically, you should explain how ATSDR uses HOD when it's available. It's important to explain whether an HOD evaluation would answer the community's questions about site contaminants and their health, and whether the evaluation would enhance the conclusions and recommendations in the final document. In particular, the community should be aware of the strengths and limitations of an HOD evaluation. Please note that a separate HOD section in a health consultation or a PHA is not required. However, it is required that we consider evaluating HOD using the decision criteria set up by ATSDR. This slide includes the decision tree that health assessors should use to determine whether HOD reviews should or could be done during the PHA process. When using this decision tree, the answer to all these questions need to be yes to meet the criteria for conducting an HOD analysis. I would also note that another important factor is to determine whether we have a sufficiently exposed population to determine a statistical increase in a health outcome. I'd like to direct your attention to the red arrow in this figure, which is pointing to the decision point for the question on whether you have a quantifiable exposed population. You will ask yourself, if we have a sufficiently exposed population to be able to detect an increase in the outcome, if indeed there was one. You should also look at the FAGM for more information and consult with your team epidemiologists. I do want to point out that site-specific HOD are rarely available or of sufficient quality to associate health outcomes with site-related exposures. A typical HOD review is not intended to, nor does it evaluate a causative relationship between exposure and a health outcome. Also, I want to emphasize that HOD must always be interpreted cautiously. There are many limitations of HOD reviews, some of which are captured on the decision tree. Some of these include causation is not determined, lack of exposure of information, long latency periods for cancer and other chronic diseases, the many confounding factors, no health outcome databases for many diseases, actual exposure of individuals may not be measured. Typically, there is no information on individual risk factors, and data are unavailable for small geographic areas. I will show you an example of this last limitation on the next slide. Here is a realistic example of a population comparison factors. that limit the utility of HOD analysis to provide useful information for our public health assessment work. As shown in this population density map, the exposed population is much smaller than the larger census block and zip code populations, which are the lowest geographic unit for which HOD are available. The exposed population is only about 2% of the census block population and only about 0.3% of the zip code population. Therefore, it would be very difficult to detect any increase in a health outcome in the 20 or so exposed persons from this site. And this disparity between the small exposed population and the census block, or the even larger zip code, makes it difficult to show a statistically significant difference between the exposed and the non-exposed populations. Another error that can be introduced is called exposure misclassification. Exposure misclassification occurs when someone who is not exposed is classified as exposed. The reverse can also be true, where someone who is exposed is classified as not exposed. Exposure misclassifications makes it more difficult to identify statistically different rates between two populations. So, in this example, you have both a small exposed population as well as a larger HOD geographic unit that does not match well with the exposed population. Here are some HOD take-home messages. First, you should ask questions before you do an HOD evaluation. Work with your team epidemiologist, who can provide you with valuable information as to whether evaluating HOD at your site is feasible and warranted. Your team epidemiologist can help you determine limitations and uncertainties of such an evaluation. Second, be sure you can interpret the results, which are the findings and limitations, and appropriately communicate them to the community. Think in advance how you would interpret the findings of the analysis, whether you think you could observe an elevation or not, and the major limitations of such an evaluation. Third, you should understand that extensive follow-up, such as additional analysis, may be necessary. Fourth, as I mentioned, an HOD section in our PHAs and health consultations is not required. However, you are required to consider HOD using the decision tree at your site. Fifth, you should seamlessly integrate HOD results with other PHA and health conclusion findings. For example, if you get an elevation of a certain health outcome and your health effects evaluation indicated that it is or is not expected from your exposure, then this should be explained. Finally, in some cases, educating the community on the benefits or limitations of HOD analysis could be a better approach than evaluating HOD. You could explain to the community that the evaluation of HOD in relation to actual exposure to the site is not likely to show an increase, and that the health effects evaluation process is the best way to evaluate the impact of site exposures and to determine what public health actions are needed. Always consult with your team epidemiologist on the interpretation and reporting of findings from an HOD review. If you work with an SME epidemiologist to conduct an HOD review for your site, be sure to educate the community beforehand about the limitations and often the inability of HOD analysis to show causal relationships between site contaminants and people's health. As I mentioned earlier, when we look at the health effects evaluation diagram, I thought it important to discuss HOD, as well as the limitations that could come into play with each of the PHA process steps. This is so you are thinking about these things while you perform other steps of the PHA process. Now we will turn to covering two other main steps on that health effects evaluation diagram we looked at earlier, which are defining exposure units and estimating EPCs. At this point, I will turn things over to Rebecca to cover our next topic, which is exposure units.
Thank you. We're now going to discuss how to define exposure units, another important step in the public health evaluation process. This concept was introduced during the webinar on the selection of sampling data. Before we get started, let's go ahead and gauge what you remember from that presentation with a quick question. I'm going to present a couple of descriptions for an exposure unit. Once I present them, please select all correct descriptions. An exposure unit is A, an area where a person contacts an environmental medium. B, also referred to as an area of exposure and exposure area. C, an area where a person would not move around randomly. And D, identified to assess potential COCs in exposure pathways. Think about how you would answer this question. Let's check how you did. Did you choose A, B, and D? They are all correct descriptions for exposure units. In contrast, the C option, that an exposure unit is an area where a person would not move around randomly, is incorrect answer, because over time, a person is assumed to move around randomly throughout the exposure unit. Now let's go ahead and refresh a bit more on this and some of the other points on this slide. Then we'll talk through how to define the exposure unit and how to select representative data for evaluating an exposure unit. During this step of the PHA process and at a very high level, health assessors identify geographic points or areas where a person may come into contact with the environmental medium of concern. Another very important point is that within those defined areas, a person is assumed to move around or contact the environmental medium in those areas randomly over time. This means that a person is not expected to preferentially access or spend more time in any one area of a defined exposure unit. This also means that people are moving around throughout the exposure unit in such a way that the average concentration of a contaminant measured in that area, as long as the samples were collected in an unbiased way, can be used to characterize long-term exposures. So, when do you need to do this? You may recall from the exposure unit primer, exposure units are defined for each potential or completed exposure pathway that is identified at a site. This means that you might not actually need to define exposure units for every medium at your site. You only need to do this if you have, in fact, identified one or more potential or completed exposure pathways. I'll also mention that sometimes you could come across other terminology that sounds very similar to exposure unit, but might have a different meaning. For example, sites on the national priorities list are often defined into what are called operable units by the U.S. Environmental Protection Agency, or EPA, and those are basically different areas of investigation. You might also be familiar with the term decision unit, but that's typically used in the context of a very particular type of sampling called incremental sampling methodology, or ISM, and it focuses on cleanup decisions. While these terms might sound like exposure units, you shouldn't necessarily expect that a site's operable unit or a site's decision unit coincides with an exposure unit. You might find this for some sites, but certainly not always, and this is something that I encourage you to be mindful of. When you define exposure units, there are a number of different factors to consider. These are listed and discussed in detail in ATSDR's guidance on exposure units, but we'll go ahead and step through a few of those briefly during this webinar. First, and perhaps above all, it is important to understand that exposure units are defined by people's activities and not by available environmental sampling data. This means that the spatial extent of an exposure unit should be largely based on an exposed population's assumed daily routines or preferences, and in some cases, relevant cultural practices that are tied to environmental exposures or might affect environmental exposures. You might also need to consider physical or even natural barriers that can limit exposure. As an example, let's say that you are evaluating surface soil ingestion and dermal contact among children playing in the backyard area of a daycare facility, and that there's a fence that prevents access to one side of that backyard play area. Since the exposure unit should represent the area that children routinely access, and in this case, play in, you might choose to define the exposure unit as just that one half of the backyard area that children use. Second, it's important to understand that exposure units can vary greatly in size. They can be as small as a single drinking water tap served by a private well in someone's home, or as large as an entire wildlife management zone with open access for hunting. Again, this is simply because the dimensions of an exposure unit depend on things like human activity patterns and access restrictions. The third item listed on this slide mentions that exposure units can vary by conditions of exposure. Let's remember that exposure units are defined by areas that people access randomly over time, and that they can differ over acute, intermediate, and chronic exposure windows. Based on expected human activities within a certain area, you might need to define different exposure units to evaluate exposures over those different time windows or durations. Because ATSDR's health guidelines are divided into acute, intermediate, and chronic durations, we particularly want to look at exposure units with those durations in mind. You'll learn more about acute, intermediate, and chronic durations in the toxicological evaluation portion of your PHA training. Let's consider a residential property with surface soil contamination. The entire lot might be appropriate as the exposure unit for chronic exposures, but a subset of that lot, say maybe a small area with a garden or a small area where children play, might be appropriate for evaluating acute exposures. And finally, sites may, and very often do, have more than one exposure unit. Let's think of an example of a neighborhood with widespread surface soil contamination. In this case, you might want to treat each residential property, or even just the backyard area in that neighborhood, as a separate exposure unit. That would be appropriate to do since residents primarily contact soil in their own yards. And it would be especially true if you have reason to believe that residents have different behaviors in their yards that are tied to exposures. Now, I'd like to ask you to think about some questions, and these touch on some of the key points that are shown on this slide. For this question, let's consider an elementary school with a soccer field adjacent to a former industrial site that has surface soil contamination, something like that shown in the graphic on the screen. Based on information collected previously, surface soil ingestion is a completed exposure pathway among elementary school children who routinely play in the soccer field. In this image, there is a secure barbed wire fence that prevents students from accessing the industrial site property. This fence is represented by the horizontal blue line that separates the two properties. For this example, let's pretend that we've received information confirming that there's no evidence or history of trespassing at the industrial site. Let's also assume that students use the entire soccer field when they play. In this figure, small blue triangles indicate the locations of surface soil samples collected around the area of the former industrial site and throughout the adjacent soccer field. The image also includes isoplests that show contaminant levels, which are found at the highest levels on site at the former drum storage area. These are indicated by the blue circle at the top of the property of the former industrial site, and then decrease with distance from that location. This image also indicates that some site-related contamination extended off-site and into the soccer field. My question to you is, how should a health assessor define exposure units to evaluate chronic exposures to surface soil among elementary school children using the soccer field? We're going to provide you with 3 answers. First, should we define one exposure unit for the entire soccer field for this scenario? Second answer, should we define one exposure unit as the field and the industrial site? Third answer, Or should we define one exposure unit as a small contaminated area of the soccer field? Well, how did you do? The first answer is correct. Health assessors should define one exposure unit as the entire soccer field, which includes both contaminated and non-contaminated areas in the field, as shown in the graphic on the slide. That is because, to reiterate again, we want to define exposure units based on where the children play and not necessarily just on where contamination has been found. So regardless of whether there's widespread contamination throughout the soccer field or several smaller areas of more localized contamination, we want to define the field as a single exposure unit. The second answer is not correct because it assumes that children access the property of the former industrial site, and we know that to not be true. If you were to decide that some children do trespass onto the site, then the site becomes a separate exposure unit that you evaluate independently from the soccer field. The third answer is not correct because it incorrectly assumes that children only play in that smaller, most highly contaminated area of the field. If we were to define exposure units in that way, we might overestimate true chronic exposures. If this scenario were different, let's say that children preferentially and routinely accessed certain areas at the soccer field, then you might want to go ahead and select a smaller portion of the field as an exposure unit. I want to mention one other thing using this soccer field example. An important consideration would be whether the surface soil sampling program for the field was biased towards known contamination and therefore not representative of the entire field. As you saw in the figure, though, samples were collected throughout the entire field, and so we wouldn't have to worry about that here. Now, let's walk through one more question. In this example, let's consider a leaking storage tank that created a large groundwater contamination plume that has affected 4 private wells at 4 different homes. This is depicted in the figure, where there is a tank farm at the box on the left-hand side of the plume. There are 4 private wells indicated as blue triangles and then some isoplests outlining groundwater contamination. For this example, let's assume that the health assessor has already determined that ingestion is a completed exposure pathway and that drinking water contamination levels are highly variable across the 4 homes. Given this information, I'd like to ask you how a health assessor should define exposure units to appropriately evaluate exposures for residents who drink from those 4 private wells. And we'll provide you with 2 possible options. The first option is to define 4 separate exposure units, one for each of the different private wells. The second option is to combine the 4 private wells into a single exposure unit. The correct answer is the first one. The health assessor should define 4 separate exposure units, one for each of the 4 different private residential wells, as shown in the figure on the slide. This is because we want to be sure that we consider where residents routinely obtain their drinking water, which in this case would be from their own private well. If we were to instead combine the 4 private wells into a single exposure unit, we would be incorrectly assuming that over time, residents get their drinking water at random from all 4 wells, which most certainly is not the case in this scenario. I'll say that this is very much like the class exercise included in the exposure unit primer, in which a health assessor is evaluating carbon tetrachloride detected in drinking water collected at 6 homes, each with their own private well. There's another similar example in the exposure unit guidance document on the FAGM resources page. If you'd like additional practice with drinking water, please check those out. I'd like to say one more thing before we move on. Let's say these 4 triangles actually represent public water supply wells. This would mean there is 1 exposure unit, because water from these public water supply wells would most likely be blended and distributed to customers. You could eventually do a more sophisticated analysis and incorporate the percentage that each well contributed to the blended water and look at how their percentages varied over time. Now that we've talked about how to define an exposure unit, let's discuss some of the sources of information that you can use to do so, as listed on the slide here. You should always review the site history, conceptual site model, and exposure pathways analysis when you're defining your exposure unit. And if site visits were previously conducted, consider any observations that were documented or photos that were taken on those visits. You can also gain a lot of valuable information from reviewing maps, using Google Earth, and speaking with members and leaders of the local community. Other good sources of information include other agencies like EPA, state, local, or tribal nations. In terms of behaviors that can determine how you define an exposure unit, you'll also want to consider things like any known institutional controls, such as fishing or hunting advisories, as well as the presence of natural or physical barriers, like a fence or a locked gate, that could limit or alter exposures. If you have a public session so the community can learn about the public health assessment process, residents will often give you insights about how people, and particularly children, might come into contact with contaminated media. They could provide valuable information about the frequency of various activities that might lead to exposure. This is also a good time to learn about their health concerns from living on or near contaminated areas. Once you have identified your exposure units, the next step is to select representative data for evaluating those exposure units. For this, you'll want to rely on some of the key concepts discussed in the webinar on sampling data, while also making sure that you select environmental sampling data that best represent the exposures within the exposure unit that you are evaluating. This often means using environmental sampling data collected within an exposure unit, but in some cases, it might also be appropriate to use data collected outside of the exposure unit, or even to use environmental modeling data such as ambient air or groundwater modeling data. If we go back to the soccer field example, an important consideration there would be whether the surface soil sampling program for the field was adequate. Let's say we identify the soccer field as an exposure unit, but the field has not been sampled. We know that not only is on-site soil contaminated, but the contamination has reached the fence line between the site and the soccer field. We might look at the contaminant soil levels right at the fence line. If those were elevated, we'd be concerned that the soccer field was contaminated, which would justify recommendations to have the soccer field sampled. Let's say that soil at the fence line is not contaminated, but we know that fill from the site was used to fill low-lying areas on the soccer field. Now, because we know that on-site soils are contaminated, we are concerned that the soccer field is contaminated and would recommend soil samples from the soccer field. Whenever you recommend soil samples to evaluate human exposure, be sure to recommend surface soil samples be collected from 0 to up to 3 inches. It's important to specify the top few inches because someone else's definition of surface soil might be 0 to 12 inches or 0 to 24 inches. When evaluating exposure from human contact, we always want soil samples to be from the top few inches of soil, and ATSDR typically recommends 0 to 3 inches. And finally, I'll add here that as part of this step, you will, of course, want to ensure that all of the data you select for evaluating the exposure unit are valid. As an example, let's consider an industrial outfall that has released a synthetic chemical at an upstream location of a creek. And let's say that this contaminant is not released from any other sources in the area. The figure on the right shows the direction of the flow and the surface water and sediment sampling locations. The industrial outfall released into the West Fork Main Creek is shown at the top of the figure. This creek flows several miles between the industrial facility and the confluence of another creek, the East Fork Main Creek, at which point the surface water is known as Main Creek, and then flows, let's say, into a large lake a few miles downstream. There's a public beach located on the West Fork, which has a designated swimming area that's marked by buoys, indicated by the dotted line in the creek right near the beach. For this example, let's assume that other areas of the creek are not readily accessible, but there is some evidence of occasional use for fishing. And for this example, to keep it simple, let's focus entirely on potential surface water exposures. Based on this information, focusing on surface water, a health assessor has already determined that dermal contact and incidental ingestion are potential exposure pathways for people using the public beach. As for fishing, they determine that people generally don't fish from the banks of the creeks, but instead do so by wading into all areas of the creeks. Thus, for this scenario, the health assessor has also identified dermal contact and incidental ingestion of surface water for trout fishers as potential exposure pathways. How should we define the exposure unit for evaluating these pathways? This slide shows the previous figure. Well, remember that an exposure unit is defined by locations where people frequent and not by where sampling has occurred. For the surface water exposure pathway for beachgoers, the appropriate definition of the exposure unit is the designated swimming area at the public beach. For the fishing scenario, exposures to surface water could occur at all locations throughout the 3 creeks. In that case, you would want to define this much larger exposure unit for this pathway. For this evaluation, we are going to consider 2 exposure units for surface water, one for beachgoers and another for those fishing in the creeks. Now, we want to select representative sampling data to evaluate each of these exposure units. As this figure shows, surface water data were collected at 3 sampling locations. This includes 1 location downstream of the industrial outfall, 1 location in the East Fork Main Creek tributary, and another location in Main Creek, where the 2 smaller creeks come together. For evaluating the beachgoer exposure, you would first want to consider the proximity of the beach to the other sampling locations, as well as the outfall. Let's start with sampling location 2 in the East Fork. Although this sampling location appears to be closest to the beachgoer exposure unit, data from this location wouldn't be appropriate for characterizing exposures at the beach, since contaminants from the industrial outfall wouldn't flow upriver into that tributary. Similarly, data collected from sampling location 3 in the Main Creek probably shouldn't be used, since the concentration of the contaminant in that area would likely be lower than the concentration in West Fork, where the beach is, due to dilution from waters flowing in from the East Fork, plus its downstream. Now, let's think about what the data from sampling location 1 tells us. My first observation is that sampling location 1 is not in the exposure unit. In looking at this more closely, I might also consider the fact that no tributaries dilute contamination levels between this location and the public beach. So perhaps we can use these data as a conservative estimate of exposure for those accessing and swimming at the beach, as just a first step. If the potential COC was measured in samples collected from this location at concentrations that are below screening levels, we might reasonably conclude there is not a possible issue downstream from the beach. However, if routine sampling at location number 1 showed levels much higher than the health protective screening levels, then you might want to recommend additional sampling at the beach area. Now, for the fishing scenario, you would want to consider potential exposures to surface water based on samples collected at all 3 locations. This is because we don't have any information indicating that fishers wouldn't be able to access all areas shown in the figure, or that they would preferentially access one particular part of the 3 creeks. For the last part of my presentation, I would like to talk through one more example, and that would be for the Gala Lumber Company, or GLC site. This example was discussed in the other PHA training webinars. As a quick recap, GLC operated from 1972 to 2002 and used chromated copper arsenate, or CCA, which contains arsenic, to preserve wood. The southwest quadrant of the map includes an uncovered drip pad where GLC placed CCA-treated lumber for many years. The uncovered drip pad is adjacent to land where a daycare opened in 2005. This daycare facility is an off-site facility off the southwestern corner of the site. At this daycare center, children play in the entire outside area surrounding the facility. That is to say that they can access all sections of the property. When they are out there playing, they can get dirt on their hands, and they can accidentally swallow the dirt. Some kids may also exhibit pica behavior, which is when they regularly eat dirt or other non-food items on purpose. Based on this information, and as Jill described in her presentation in the Exposure Pathways webinar, dermal contact and ingestion were identified as completed exposure pathways for surface soil for the past, present, and future exposure scenarios. To evaluate these exposure scenarios, we would want to define one exposure unit for the entire outside area of the daycare center. That is because, as I said before, we know that children can access all areas of the daycare property. To evaluate that exposure unit, we would want to consider the 18 discrete surface soil samples that were collected on the property. The numbered samples are included in the legend on the bottom left of the figure on the right side of the screen. The main point here is that all 18 samples were collected within the area that we just defined as our exposure unit. Now the health assessor needs to compile data for that single exposure unit that we just defined, which again is that outside area of the daycare property. In this case, we're going to focus on arsenic, which had a maximum concentration that was above recommended comparison values, or CVs. The health assessor has gone through and confirmed that the data are indeed representative of the exposure unit and weren't collected in any sort of biased manner. Therefore, they then go ahead and compile arsenic concentration data for the 18 surface soil samples collected on the property in a table like the one shown here. This table includes the sampling location IDs, the dates that each of the samples were collected, and the measured concentrations of arsenic in units of milligrams per kilogram. These are the data that you would then use to calculate an EPC for that exposure unit. I'm about to hand this off to James to discuss how to calculate EPCs for exposure units. But first, I'd like to remind you that you can find more information in ATSDR's guidance for identifying exposure units for the public health assessment process, which is available on the FAGM resources page. You can access the FAGM website at https://www.atstr.cdc.gov/pha-guidance/index.html. I encourage you to read through that guidance whenever you have a chance to learn a bit more on some of the topics we touched on here today. And James, I'll now go ahead and hand it off to you.
Thank you very much, Rebecca. I really appreciate the job you did with helping develop the EPC guidance and the exposure unit guidance. In our work, EPCs are typically informed by environmental sampling results. Environmental samples provide important insights on contaminant levels of sites of interest, but those insights are never complete. We will never have contamination data, for example, for every single fish in a lake that people fish in, for every drop of water that people drink, or for every bit of air that people breathe. Instead, we must use available environmental sampling data to estimate human exposures to contamination levels that are not measured. As Rebecca mentioned previously, sometimes there are modeling results that help inform EPCs, but in this study, we are strictly going to be talking about environmental sampling data. You should be estimating EPCs for potential contaminants of concern for each potential and completed exposure pathway in the appropriate exposure unit using the appropriate exposure duration. Remember that you should be able to relate your exposure point concentrations in some logical way to an actual person's exposure in the exposure units. For instance, if you had a bunch of residential soil data from different properties and you wanted to average those together to get an EPC, unless you have somebody who lived in all those houses at once, that would not be a reasonable EPC. Likewise, if you had different wells that were connected to individual households, you would consider each well as its own unit to calculate an EPC. You would not necessarily combine the data from those wells together just to get the sufficient sample numbers you need to calculate a UCL. As I said previously, we will typically be using environmental sampling data to estimate exposure point concentrations. But which statistics do we recommend using? Well, that's going to depend on a couple of things. First, it's going to depend on the sample collection approach. It's really important to go back to the data quality objectives of the sampling and figure out how they were doing their sampling. That's going to help guide what to do with calculating the EPC. Second, the characteristics of the data set are important, like the sample size, the number of detected and non-detected values, and how well the data fit a distribution, which is a statistical model of the data. And third, the types of questions that we're going to be asking about the characteristics of exposure. Are we interested in figuring out the concentration that would represent an acute exposure? Or are we interested in more of an intermediate or even a chronic exposure? Let me say that I appreciate the fact that what we're throwing at you can be a little complicated and daunting if you don't have much experience in doing this type of analysis. I think, compared to other environmental health professions, as ATSDR health assessors, we are asked to deal with probably the broadest range of types of environmental data. We as health assessors are often assigned different sites and might be dealing with air contamination or water contamination or biota contamination with different routes of exposure. This variety makes our work interesting, but also presents challenges because sometimes data sets are robust and sometimes they aren't. This is why we developed the EPC guidance and the APC tool to help you in making decisions about how to identify the best and most health protective EPCs to use in estimating doses and concentrations. Keep in mind, broadly speaking, with some considerations, you are generally going to be using maximum values to represent situations where you have very small sample sizes. And you might be using maximum values in some situations where you have acute exposure concerns. When you're looking at chronic exposures, you're going to tend towards needing to estimate something called an arithmetic mean. This is the value that mathematically relates to the average dose a person is exposed to. Other statistics might be presented, and they definitely have their uses. But ultimately, if your long-term goal is to figure out what the total amount of that someone is exposed to, or what the average dose is over time, then you're going to, in some way or another, estimate the arithmetic mean. For discrete samples, in other words, samples that are representing single points in time or space, we need to use statistics to try to ensure that the arithmetic mean that we calculate from these samples is not an underestimate. To ensure that we don't underestimate the mean, we'll be calculating something called a 95% upper confidence limit. And we typically abbreviate that in shorthand as 95 UCL. And we're going to use that value as an exposure point concentration. Now, we will talk about non-discrete samples, which are samples that are composites of multiple subsamples that are combined together. If these samples are collected right, with sufficient sample mass and sufficient number of sample increments, they could develop a very reliable estimates of mean exposures. In that case, we're going to tend to recommend an arithmetic mean and maybe not so much the need to do statistical manipulation to get an upper confidence limit. That sort of uncertainty should be controlled for in the data quality objectives of developing a good sampling program for non-discrete samples. During this process, be sure to review the sampling design and contact an ATSDR statistician if you need assistance estimating EPCs. Whenever possible, it is key for ATSDR scientists to provide input to partners during the sampling design process. Now let's talk more about the types of EPCs ATSDR uses and how to decide which is appropriate based on your sampling data. We will begin by discussing discrete sampling. When using discrete samples to calculate an EPC for evaluating acute exposures, what are we talking about? A good example would be for soil pica behaviors where a percentage of children will intentionally eat soil. This might be an appropriate scenario to consider in our Gala Lumber Company, where the exposed population is children. All the statistical manipulation really does not happen in a vacuum. It all ties together, which is one aspect that makes this very hard to teach. There are a lot of considerations to go into what you're doing, and one of them here is the fact that you have children as an exposed population. The acute EPC exposures are going to require some considerations. For instance, if you're looking at peak exposures, you need to consider the influence of atypical events, such as sudden chemical releases. And then there's something a friend taught me about fireworks. You can look at metals data over time, and every time New Year's and the 4th of July starts to roll around, people start setting off fireworks. And then the colors in them are determined by the metal content of the fireworks. Inevitably, there can be changes in air quality that are attributed to these sorts of events. There also may be seasonality and trends in your data that will affect how you average data for short-term exposures. You also need to be on the lookout for data quality issues like laboratory contamination. Yet one more reason to do a data quality assessment of your data set. For selecting EPC statistics for acute exposure, the bottom line is that whether you use an acute value for some sort of average value for your EPC, it's going to be guided not only by human behavior, but also by the toxicology and the science for the contaminant. You will need to consult the minimum risk level documentation for the contaminant and determine the duration of the key toxicological study that was used to derive the acute minimum risk level, called an MRL. If the acute MRL study was based on exposure of 1 to 3 days, that will tend to say that the maximum value for your data set would be more protective than the mean value. If the acute MRL study was based on 4 or more days of exposure, that tends to get into an area where the 95 UCL may be protective. Again, it's not a magic line between 3 and 4 days, it's a gradient, but typically the longer the exposure, the more the arithmetic mean is going to characterize the total dose that you're going to be exposed to during that period of time. For intermediate and chronic exposures, you're going to be calculating an upper confidence limit of the arithmetic mean or using some maximal value if you have a small sample set that you're working with. If you're going to end up calculating an upper confidence limit, you need a certain number of detected samples to create a valid upper confidence limit. The reliability of those limits starts to go down as sample sizes go down. To calculate a 95 UCL from your data set, typically the rule of thumb is 8 or more samples, but you also need to have enough detected values in your data set. When you have 8 to 19 samples, you will need 4 or more detected values to calculate a 95 UCL. If you have 20 or more samples, you need to have at least 20% of your samples to have detected values. If neither one of those two rules are met, you'll need to use the maximum detected value as your EPC. You'll also use the maximum detected value if you have 7 or fewer samples for your exposure unit. The good news is that the EPC tool will apply these rules for you when you enter your data using the EPC tool template. But now you understand why the EPC tool will calculate a 95 UCL for some data sets, but use the maximum value for other data sets. There are flowcharts in the EPC guidance, and I'm going to be showing you a limited example of how to go through these flowcharts and calculate the EPC for the arsenic data at the GLC case study daycare. But before that, let me just step back. I think probably one of the more important points in my presentation is why we do statistics. Why go through the trouble of using these rules? The bottom line is that what we're trying to do is control error. If the PHA process, we specifically do not want to have a high possibility that we will underestimate the exposure when identifying the exposure point concentration. We do not want to be in the position where we tell people it is safe when in fact it is not safe. So how do we control for that type of error, and how do statistics help us with that sort of problem? This is best shown by example. Let's imagine a soccer field where a herbicide had been applied to the soccer field as a weed control, like the picture shown on this slide. The main concern here is the children's level of exposure to the pesticide while playing on the field. To investigate this, we would need a good estimate of the pesticide concentration that the children are potentially exposed to throughout the soccer season and throughout the entire field. That would tend to be an arithmetic mean. Since we cannot realistically sample every single particle of soil in the field, we can't just scoop it all up and stuff it into a gas chromatography mass spectrometer to get a result. We're left to collect samples. In this example, let's pretend that we were presented with laboratory results from 10 surface soil samples collected at random at various locations in the field, and we determined that the average concentration from these soils was 0.25 parts per billion. How confident would we be in that average? Do we think that the value reflects the average concentration that children would be exposed to while playing on the field? Do you think that the actual true average is higher or lower than our sample average? Those are rhetorical questions. Now, imagine we collect two random data sets from the same field. On this slide, there are two aerial views of the soccer field with 10 black squares that represent differing sample locations dispersed on the field. Let's say EPA went out and collected their sample, and the contractor for the county park system went out and collected their sample. And they both used the same collection methods and analytical workup. Even if everything is all the same, almost inevitably, we're going to end up with two different sample averages. Let's say the EPA sample is 0.25 parts per billion. And let's say the contractor came up with 0.62 parts per billion. Again, we want to know what the true average concentration is, but we have two different results. So, which is correct? Well, the bottom line is we really don't know. The theory is that this average that we collect from the sample is going to be random, and it's going to vary from sample to sample. To illustrate with another example, this slide includes 9 aerial views of the soccer field with 10 black squares that represent different sample locations dispersed on the field. There will always be sampling error. If we went back and collected 10 samples from the 9 soccer fields, we're probably going to get to the point where we're stuffing the whole thing into an analytical device. But if we did that, every set of samples would have its own individual sample mean, as shown in these soccer field images. One would be 0.25. Let's say the next is 0.56, then 0.85, then 0.35, 0.45, 0.39, 0.67, 0.58, and 0.28 parts per billion, as indicated in the examples on this slide. But what will happen is that these sample averages will be clustered about the true mean. We don't know what that true mean is, but you could come up with a very good estimate by taking the mean of the sample means. There's going to be some variability, which we can calculate from the amount of variability in our individual sample results. That variability will drive how different the individual sample results are. If we have very low variability, the sample means are going to be clustered together. If we have very high variability, the sample means are going to be more dispersed. But there's going to be a general tendency for these sample means to be more frequently closer to the true mean than farther away. Likewise, the amount of spread of those sample means is going to vary depending on sample size. We're dealing with a sample size of 10. If we had 20 samples in our data set, the clustering of these sample means will be much more closer and much more reliable. Like I said, we can use the data from our samples to estimate how variable contamination is, and from that, with the sample average, we can draw some inferences about how frequently a sample mean will be within a given interval about the true mean. In other words, and this is a very key point here, I can't tell you based on a sample mean if it's the true mean. But if I'm able to calculate an interval using this technique, then I can tell you a given frequency that I can expect that interval to contain the true mean. That is what's called a confidence interval and how we're referring to it. In our soccer field example, I can use the 10 samples, figure out a sample variance and a sample mean, and then calculate a confidence interval. This confidence interval assumes that all the statistical requirements are met, and 95% of the time, that interval is going to contain the true mean. When we calculate confidence intervals, we are going to use one of two approaches. The parametric statistical approach is where we assume the data are described by a probability distribution, and typically environmental distributions are modeled with normal, log normal, or gamma distributions. There are other distributions out there, but these are the big three in the environmental statistics world. We'll be using parametric statistics with smaller sample sizes. A limitation of parametric statistics is that it's difficult to know with small sample sizes which distribution to pick. And there are cases where a single distributional model of the data may be problematic. As an alternate to parametric statistics, there are non-parametric methods for estimating confidence intervals. For these, you don't have to pick a distributional assumption of the data. They let the data guide the inference, and they are not subject to the problem of picking a distribution. But the problem is that they generally require a larger sample size to be effective. The general principle is when we have small sample sizes, we try to fit a model to the data to help us. When we have enough of a sample size, we try to let the data guide us, and I will show you where and why we like to go with the non-parametric approach in a minute. You may have noticed a little bit of heterogeneity in my terminology. Earlier, I was talking about an upper 95% confidence limit. This is really the end of the interval that runs from 0 up to the upper confidence limit. And 95% of the time, it's in repeated sampling, it should contain our true mean value if every assumption about our confidence limit method is met. To rehash, the 95% UCL is expected to exceed the mean on repeated samples 95% of the time in the same exposure unit. That gives us confidence that we're not underestimating the true mean, even though we don't know what that true mean actually is. We use this value to be sure we are not underestimating our exposure and not creating a situation where we're telling people that, hey, it's safe, don't worry, go about your business, when in fact it might not be safe. That is something we do not want to have to walk back, and there are some consequences to using this approach. Basically, what is happening is that we are assuming that our site or our exposure unit is presumed to be a hazard unless the environmental sampling data can statistically show otherwise. If this were a trial, the exposure unit would be considered guilty until the data prove it innocent. And again, in statistics, that kind of assumption is needed to control for what we talked about, where we don't want to be in a situation where we're telling something that this is not a problem, when in fact, it is a problem. Now, for some further comments on UCLs. The 95% UCLs can vary from sample to sample, and comparing one UCL value to another UCL value does not tell you if concentrations are higher or lower. For instance, let's say we had 3 soccer fields in this park, as shown on this slide, that we are talking about. Even though we don't know it, let's say hypothetically, the true averages were 0.25, 0.3, and 0.67 parts per billion. If we calculate UCLs, we would get 0.62, 0.58, and 0.82 parts per billion from the samples we collected in these fields. It would not be appropriate to claim that the first soccer field has a higher concentration than the second soccer field based on the UCLs being higher. If you want to compare one field to another or compare all fields to each other, there are different types of statistical confidence or statistical tests you can do. These are supported in applications like ProUCL. If you're just doing one and the other, you might want to look at two-sided comparison test or alternatively, you can generate two-sided confidence limits if you're really interested in discerning differences across the fields. Another important note is to be cautious about comparing UCL values to published background concentration. Let's think about it. If the true mean concentration of what you're looking at is exactly at background, we would absolutely expect a UCL value to be higher than that background level 95% of the time. If your UCL is higher than your background level, that doesn't tell you if your true mean is higher than that background level. However, if your UCL is less than background level, you can be confident that your values are in fact less than background. If you want to make this type of comparison, it's not hard. What you need to do is look at something called a one-sided test. And again, this is available in the EPA application Pro UCL. Alternatively, again, you can generate two-sided confidence limits and ascertain if your sample mean could be higher or lower than your background levels. You need enough samples to reliably calculate a UCL. There are always exceptions to these guidelines, but again, in general, look for these two criteria in the data. If a data set has 8 to 19 samples, then 4 or more samples must have detected values. If a data set has 20 or more samples, then at least 20% of the samples must have detected values. Again, these are minimal criteria, a rule of thumb. You're never going to find a statistician that tells you, yeah, those are enough samples to collect. The more, the better is usually the case. This is figure 1 showing how to select EPC statistics for different exposure durations from the EPC guidance. These are flowcharts in the guidance like this that have boxes with decision points to help you walk through the entire process step by step. You can find figure 1 in the EPC guidance for discrete sampling. Starting with the 18 samples that we had in our daycare, let's calculate an EPC. We are not dealing with lead or asbestos. If you've got those contaminants at your site, you're going to need to be talking to our SME for those topics. We have guidance for evaluating PAHs and dioxins. We won't be covering those chemicals in this webinar, but the guidance to evaluating them is on our PHAGM resources page. Let's continue with figure 1. If you're evaluating a data set based on multi-incremental sampling methods, consult with our ADS group. If you answered no to all the previous questions, you'll apply the criteria we mentioned about less than or greater than 8 samples, minimum number of detected values, and the 20% rule. You'll select either the maximum concentration or the 95 UCL for acute, intermediate, and chronic durations. For acute exposure, you're going to consider the toxicity of the chemicals and whether you should have used the maximum concentration regardless of the number of samples. Again, consult with your ADS office when needed. Now I'm going to talk about ATSDR's web-based EPC tool, which does the EPC calculations for our health assessors. ATSDR provides access to approved users, and you can request access by emailing phast@cdc.gov. Again, that's P as in Papa, H as in Hotel, A as in Alpha, S as in Sierra, T as in Tango at cdc.gov. Data are uploaded into the EPC tool through the site's data import template. This screenshot shows the fields in the template, which include the exposure unit, contaminant, CASRN, media, concentration, unit, detection flag, and sample ID. The screenshot shown on this slide includes this information for arsenic from the 18 samples at the daycare facility. The detected flag is 0 for non-detected contaminants and 1 for detected contaminants. Since arsenic was detected in all 18 samples, this column includes all ones. The concentrations ranged from 1.3 to 1020 parts per million, or ppm. This screen shows the results of the EPC tool after I imported the data set we talked about. This shows that there are 18 observations, 1 exposure unit, 1 contaminant, 1 type of media, and 1 EPC to be calculated. I used the Calculate EPC button in the EPC tool to get the results on the next slide. Let's talk about those now. After importing our data, the following are the main results of the EPC tool. The number of observations is 18. The EPC value is 774.6. The units are all in parts per million. The recommended EPC type is a 95% UCL of the mean, and this data this data set contains between 8 and 19 records. Now, I want to show you some of the great data visualizations that the EPC tool offers to help you show the data in different ways. This first visual I'm presenting here shows our arsenic concentration data using what is called a box plot. Beginning from the top of the figure, the box plot lines represent the upper fence, 950, or maximum level, 1020. The third quartile, Q3, is 552.5. The median, or 50th percentile, is 380. And the first quartile, or the 25th percentile, or Q1, is 277.5. The lower fence value of the data is 1.3 and is the minimum of our imported data. The dot above the upper fence represents an outlier, potentially, of 1020 parts per million. This figure shows a histogram generated by the EPC tool of the imported arsenic soil data. It presents a density curve based on the histogram of the arsenic data. The arsenic concentration is shown across the bottom in ppm. The density levels are shown on the right-hand side, going from 0 to 0.0015. The count is shown on the upper left vertical bar, going from 0 to 6. Now I will present a series of figures that show QQ plots of the arsenic concentrations so we can determine if a normal, log normal, or gamma distribution has the best fit. The vertical axis of each figure shows the quantiles of the imported data, and the horizontal axis shows the quantiles of the assumed distribution. When the distribution of the imported data is similar to the assumed distribution, the points on the QQ plot will approximately lie on the diagonal line shown in the figure. The figure on this slide shows the normal distribution QQ plot, where the quantiles of the normal are mean equals 0 and the standard deviation equals 1. This graph shows the gamma distribution QQ plot for arsenic. The quantiles of the gamma, as shown, are the shape equals 0.8654 and the scale equals 492.1. Lastly, this graph presents the QQ plot for the log normal distribution. The assumed distribution, as shown on the horizontal axis, have a mean of 0 and a standard deviation of 1. All right, we've talked about using the EPC tool to calculate your EPC and the data visualizations it has to help you look at the data in different ways. Now let's turn to discussing non-discrete or composite sampling for EPC calculations. We've talked about how non-discrete samples can do a very good job, if done right, for estimating chronic long-term mean exposures. One of the challenges with non-discrete sampling is for acute exposure. This is one place, if you think you're going to be doing composite sampling or incremental sampling designs, You really want to be at the table for discussions on the sampling program's data quality objectives. If we suspect that there are areas where children have more frequent exposure to acutely toxic chemicals, you want those responsible for the sample collection to lay out a sample design that captures these smaller exposure units. I know it's a little contradictory to how we defined our exposure unit before, but basically we can use maximum samples if we do discrete sampling. If you don't have discrete sampling and all you have is an average and they didn't have subunits of that, then you're going to not be able to say very much about high areas of contamination and acute exposure. In this case, you've got to let the behavior of the population and the information you gather from the community really guide how you do your type of sampling design. When you have multiple composite samples from the same exposure unit, you need to determine whether the composite samples represent equal or unequal sizes within that exposure unit. Methods exist for weighting the composite results that come from unequal areas. I'm going to make a point that sometimes when looking at our data for estimating EPCs, we will encounter both discrete sampling and non-discrete sampling designs in our sites because different organizations come in and do sampling at different times. For example, composite samples may be collected across a large residential property to evaluate average concentrations, and discrete samples may be collected from certain areas that the property owner believes are unique relative to the remainder of the property, such as play areas, hotspots, or the center of a soccer field with barren soil. Be aware that composite and discrete sampling results are not interchangeable. You can't combine non-discrete and discrete samples into a single data set and calculate an EPC. Estimating EPCs when you have both types of samples will require a little bit more than the statistical techniques that I'm showing here in this presentation. For assistance with this topic, you should contact a statistician who is knowledgeable about how to weight discrete and composite samples. And here are some final points I'd like to make. ATSDR's non-discrete sampling guidance does not apply to all contaminants and all types of sampling. For lead and asbestos, you will need to consult the subject matter experts. For dioxins and furans, you have to do some pre-processing to calculate what we call toxic equivalents, or TEQs, to account for the joint additive effects of dioxins and furans as outlined in ATSDR's dioxin guidance. Refer to the ATSDR discrete sampling guidance for discrete samples and ATSDR's guidance for PAHs for those analytes. You can find ATSDR's guidance documents on the PHAGM resource page. One thing to look out for when you're doing your exploratory data analysis is to be aware of dependent data. If you have samples that are not very separated in terms of time, so samples are collected every minute or even every hour or even every day, those individual samples are going to be related to one another. They're not going to be independent. If you have samples that are very close to each other in terms of space, that's going to create something called autocorrelation. Actually, the temporal autocorrelation I described could also be spatial autocorrelation. But at any rate, if your data are close together in space or time or both, that's going to potentially affect how your UCLs perform. And in that sort of situation, you're going to definitely need to consult with a statistician for help. And lastly, I want to mention some overall summary statements. The bottom line from Rebecca's presentation, as we talked about, is how critically important it is to define our exposure. Don't just allow the available data to let you make up whatever exposure you think is there because you have sampling data. Your exposure units have to represent people in a way that approximates the real world. There are a lot of considerations that have to be made with that. You need to be cognizant about estimating your exposure point concentration. I've given you some taste of what goes into it. There are more resources available that you need to use. We also talked about today about the health outcome data, or HOD, and the decision criteria for when these should be included in your PHA process. All of this information combined is the last stop before you get to the really big lift of conducting the scientific evaluations in the PHA process, which are covered in other webinars. And that includes our webinar presentation, and thank you for taking our training.